recording. Okay, I'll start with just another nice example of a case. Let me show my screen here. All right, so this was a young guy who came in short of breath, and I don't have a radiograph, but have this CT. Looks like this, where we have extensive ground glass opacity, this nice subpleural sparing, pretty extensive, sort of perilobular thickening here. So you've probably seen this, a little bit of septal thickening too, but this is another vaping-induced lung injury that came in. Vaping marijuana, so THC, not CBD oil. And so this is one of the patterns we've described as this sort of organizing pneumonia-like pattern with this very extensive abnormality. And the subpleural sparing seems to be a commonality in many of the patients. I'm not sure why. We don't really have any pathophysiology, but very interesting case. And I had another one also. I'm not going to show it. It looks pretty similar, but we did have two this week. And you've also seen on the news the administration's talking about banning flavored e-cigarettes. So a lot going on. Oh, and just for fun, he also has a left SVC, a duplicated SVC, so no brachiocephalic vein, non-contrast study, but does big coronary sinus should always make you think about a left SVC. All right, so that's that one. Now let's, this is a kind of an interesting case. So this is an older man who presented to the emergency department with some chest pain. Oh, good, David's on. So, hi, David.
How are you?
Good. It's just you and me today.
What, right?
It's just you and me today on. Yeah. So I just showed another vaping case. Looks like all the other ones that people have seen, but I think you'll like this case. So this is an older man. I think he's in his 70s, presenting the emergency department, chest pain. And you can see he's got this diaphragmatic eventration, sort of small lung volumes. And I'll come back to the frontal view. On the lateral, there wasn't a lot going on, but I did see this sort of right paratracheal abnormality, and it's a little full above the aorta, suggesting it's sitting behind the trachea a little bit. And then on the lateral, it's a little full up in here, but unclear really what that was. And he had no previous imaging, so they ended up getting a CT for non-contrast for some other reason. But I was excited because I was able to explain what this is, and I don't think I've ever seen it. I wish it kind of were a contrasted study, but he's got an aberrant subclavian artery. So this explains the right side of it. And on the left, there's the left subclavian artery coming off, and you can see it's a little dilated, it's got calcium. So I think this is a common origin of the subclavian arteries, where you got the right, the aberrant right, and the left coming off. You can see it's pretty tortuous, it loops around and goes out. And I cannot recall ever seeing a common origin of the two subclavian arteries.
Wow.
Yeah. If I had contrast, I could probably make a nice 3D of this, but I think that I did have, if you do I'll do one of Howard's tricks here. You can see, well, actually I don't even need to. There they are, and that's causing that radiographic abnormality of a biapical mass, sort of a fake out there. I mean, we've seen aberrant subclavian arteries cross over, and you can sometimes see them indent on the trachea, but this is the other side as well. And it is a little dilated as well, so that's why I think we see it big like this. So that's just a fun case. All right, I'll show you the vaping one real quickly, David, since you're on. Young guy vapes THC oil, has that extensive organizing pneumonia-like pattern. And typically they respond pretty well to steroids. That seems to be the trend in most of them. All right, this is an interesting case. This is a young guy in his 20s with testicular cancer and getting standard treatment, which includes bleomycin. And of course, oops, hold on, there we go. It says my screen is paused. I'm not sure why. There we go. So bleomycin, of course, is very toxic to the lungs, and a fair number of patients who get bleomycin get some sort of lung toxicity. It's usually mild, but it can manifest most commonly as organizing pneumonia. It can go on to fibrose. It can also cause severe lung injury and death. But he has this other finding. So he's got some patchy consolidation in both lungs, but then he's got these cavitary spaces. This one has a fluid level in it. And if we go to the lateral, there we go. You can see there's a nice fluid level in this one. So he got a CT angio, And you can see not only that, he's got pneumothorax on the right, but then nice peripheral consolidation, some nice example of organizing pneumonia. But then he's got these cavities with a little bit of fluid, and that's the one we saw in the radiograph. But nice organizing pneumonia. It's even pulling back on the pleura a little bit in multiple areas. So I've never seen drug toxicity or organizing pneumonia cause a cavitation or a pneumothorax, and he never had lung metastases from all his staging, so I don't think it's a necrotic metastasis. So I think he has two things going on. I think he's got bleomycin-induced lung injury. They worked him up for the infection, made sure he didn't have septic emboli because his counts were a little low. His echo was negative. His blood counts were reasonable. Everything was negative for the infectious workup. They bronched this area down here in the left lower in the lingula area and got nothing. All the infectious things seemed to come back negative. So I don't know what caused this. I presume it was infectious. It looks like septic emboli that had excavated and cavitated. His pneumothorax got better on its own finally, and they treated him for bleomycin toxicity. So I don't know if you have any thoughts on this. I'll show the coronal.
Huh.
That's what we said.
Okay, what was his original tumor, Jeff?
It was a testicular cancer. He never had lung metastases. It was just confined to the abdomen.
Okay.
So,
I'm drawing a blank.
yeah. So they treated him for a presumed infection and treated him for bleotoxicity, and he got better. So, I don't know. I've never seen bleotoxicity alone do cavitation. It doesn't make sense to me because it's usually an organization, not a necrosis.
Right.
Okay, here's another interesting case, which I think David will like, and I'm curious what you think. So this patient is, how old is he? I forgot. Older patient, worked on a farm for years, was exposed to silage and silage gas. I was sick of it many years ago, retired from a farm, but still lives on the farm and worked in just a sales office for many years. And he presented to us for evaluation of his lung disease. And he's got an interesting imaging. So he's got, I think, two major patterns. We've got extensive bronchiectasis, and it's confined to sort of the fourth, fifth, sixth orders, almost like you'd see with a Williams-Campbell-like picture. But it does go out a little bit further, but you'll see the main bronchi are relatively, and the lobar bronchi are relatively happy. It's also strikingly mid and upper lung predominant, mostly in the upper lobes, so looking like CF or ABPA distribution. And then on top of that, he has this mosaic attenuation. He has air trapping, but a lot of it is associated with the bronchiectasis and the small airway nodules. And he also has pulmonary fibrosis that is basal predominant. I think he's about 70. So the question is, are these all related? Is this HP? Is this IPF plus something? And I don't have a good answer, but what I think happened, I wonder with that silofiller's lung, they usually get an acute lung injury first, and then they can get a constrictive bronchiolitis down the line. If the airways disease is all related to that previous exposure, and that he either has pulmonary fibrosis from IPF, but happens to have the background airways disease, or he has chronic HP. The good news is he doesn't have a lymphocytosis, and so is going to be managed as pulmonary fibrosis. We don't know which one, but with an antifibrotic. But I thought it was interesting because I don't think this airway disease, this isn't the type of bronchiectasis we see with fibrotic lung disease. To me, this is primary airways problems. And they're not particularly thick. A few of them are, but a lot of them aren't, that you might see with sort of a Williams-Campbell where you just have abnormal, I mean, these are thicker. The Williams-Campbell ones sometimes are a little bit thinner, and these look more like they're related to the downstream stuff.
Yeah. I like the idea. Basically, the silofiller's disease is an acid burn to the lung, and so you'd expect there could be large airways disease. So it's nitric and nitrous oxides, I think, that they get from silage. And then this guy at his age probably has had more than one thing. So there are plenty of opportunities to get hypersensitivity pneumonitis on the farm too.
Right.
So this looks to me like chronic HP, along with some lung injury that would be consistent with inhaling, nitrous or nitric oxide, and getting, combining with water, that would give you acid in the lungs. So I think he burned his bronchi.
Mm-hmm. That would make the most sense. Okay, this is a cool case, and I did a literature search quite extensively and couldn't come up with a lot, but this is a 2-month-old with Menkes syndrome or disease. It's also called kinky hair syndrome, and it's a disease of copper metabolism. And the only thing I was able to find that made a lot of sense, and let's see if I can share it here, is this. You can see this from Genetics Home Reference. This is a put out public, but it talks about the mutations. So this is an X-linked syndrome. It's pretty rare, as you can see, and most of the cases are spontaneous mutations. But they get this funny-looking hair. You can see it has a bunch of synonyms for it, and a lot of neurodegeneration. And most of the patients don't live very long. But the reason I'm showing this case is from a cardiovascular standpoint. Is they were looking for an anomalous coronary, and that's where this started. And he does not have an anomalous coronary, but what he had, you can see he's got some big bronchial arteries. And if we go down to the abdomen, I think that's where it gets more exciting, is if we follow the abdominal aorta as we get down there, we will see the celiac artery, for example, is dilated in multiple areas. The superior mesenteric artery, replaced right hepatic coming off, replaced hepatic is dilated. And then he's got these renal artery aneurysms. And then if we go down lower, you can see all of the mesenteric vessels are all sort of beaded looking. And so apparently they can get sort of lots of aneurysms because it affects the copper metabolism error of the problem with the copper is they don't form normal collagen, so they get abnormal connective tissue, and this explains the aneurysms. I just couldn't find a lot in the literature about it, but it's sort of a diffuse arterial, sort of medium caliber vessels seem to be involved, even down here at the groin. See, I can make a
wow.
Yeah, it's impressive, and I've never seen a case of this before. It's very rare. But they could do the genetic test. There we go. You can see all these aneurysms really nicely laid out, kind of everywhere. But essentially, it doesn't affect the pulmonary arteries. And I couldn't find any lung manifestations, and I'm not sure why it doesn't do much with the subclavian. But yeah, so Menkes disease or syndrome, also called kinky hair. Oh yeah, and here's another resource. Let me show this one if I got the right one. That's the wrong one. This one here. There you go. National Organization for Rare Disorders. This is an interesting database. You can find things, but it talks about a little bit of a discussion about signs, symptoms, causes. So it's not just a target. It's targeted to healthcare providers too, but also patients. And you can see it's pretty rare in some related ones. And Wilson's disease, of course, is another disorder of copper metabolism, but totally different manifestations. So that's just a crazy one. All right, and then my last case, this is one, it took forever to get pathology on, but we finally have a diagnosis. So this is a 43-year-old male who presented to the hospital with chest pain. This is his frontal radiograph at the time of presentation. And here is his lateral radiograph, and it looks like some atelectasis and not much else to get terribly excited about. It's hard to see the posterior wall bronchus intermedius, but see a little fullness back in that area, but not much to get excited about. So he got a CT scan, and the CT scan showed pericardial effusion and then this mass in the mediastinum with a mass effect on the left atrium pulmonary veins, but it also seems to extend out into the right hilum a little bit. There's a little too much thickening behind the bronchus intermedius, and it goes down, has a little bit of mass effect on the airway as well. And then very subtle, there seems to be, it's hard to tell if it's extending into the vein here or if it's just pushing it up. It's solid tissue, so in this location, not too many things we think about, but I would have guessed lymphoma given how homogeneous it was, and then sarcoma, because it's a big blob in the mediastinum, and it's not a duplication cyst. It clearly is having a mass effect on things. He had an MR, which I didn't include, that actually was underwhelming. It didn't show a lot of signal abnormality, very little enhancement. So the thought was maybe it was a pericardial cyst that got infected, but I've never seen that, and I don't like its mass effect. But either way, he needed a biopsy, and they biopsied it, and on the frozen, it was initially thought to be lymphoma because it had a bunch of small cells, but then on the permanent, it turned out it was, I'll bring it up here, is a sarcoma. And why they thought it was lymphoma is they were a bunch of small cells that looked the same. So these are the small round blue cells. So the Ewing sarcoma family of tumors, and they did all of this immunocytochemistry, but there's specific genetic rearrangements for these, and I didn't include the specifics, but this CIC rearranged one is consistent with is an aggressive small round cell tumor. So it's a Ewing sarcoma type tumor, very aggressive. Unfortunately, the patient died before anything could be done. He was having tamponade and stroke, so I presume it was growing quickly, invaded the left atrium and all that. But a very rare location, and even rarer in a patient 40 years old. But I always think about sarcomas when I see blobs in the mediastinum, but I would have favored lymphoma just given its homogeneity, because usually the Ewings are very aggressive, and ones I've seen in the chest wall, are very destructive, and can even be hypervascular at times.
Wow.
Yep. Okay, I think that's everything. All right, David, do you have any cases?
I have one case, and I just had three fantastic cases this morning, but I have not had time to gather those. I'll try those next week.
Okay.
So here is a person whose radiograph, and this is back in 2013, looks pretty normal. There is a port catheter. This person does have a history of malignancy. I'll have to research what the status was. I think there's some degree of immune compromise because of cancer treatment. So this is 2013. I don't have a closer comparison to our current radiograph, which shows this big round abnormality posteriorly in the right lower lobe. So it looks like a superior segment rounded abnormality. And the person had some infectious symptoms. And here's what it looks like on CT. There's pleural effusion. There's this dense consolidation in the right lower lobe with air bronchograms. And there's maybe a little consolidation in the left base. So very big rounded abnormality back here. And with time, let's see, a few days later, this thing's not going away. Here it is again, this big dense consolidation. So this mass-like thing in a person with some degree of immune compromise, I believe, I will clarify this before I post the case. And this turns out to be Legionella McDadei again, which in my experience often presents with rounded consolidation that often resembles Aspergillus even, Aspergillus infection, except it usually progresses much faster than Aspergillus does, or even than Mucor does. So dense consolidation in this case turns out to be Legionella McDadei. And with treatment, this thing faded slowly. And our current imaging from earlier this week shows continued regression. Now, ultimately, there was involvement on the other side too. There was consolidation on this other side that shows up more on later CTs, and it's all getting better currently. So Legionella McDadei can give you round pneumonias and even nodules that you might mistake for fungus at first blush.
Yeah, you've shown some of those before. That look exactly like fungus.
Yeah. Except progression is usually faster.
Right.
So, yeah.
Cool. Great.
I'm sorry I don't have others ready to go.
That's all right. It's a lean week today. Yeah, so Travis and Howard should hopefully come back next week. Does anybody else online have anything? If not, we will just end early.
So, Jeff?
Yep.
With the vaping cases, were you going to show me the vaping case from earlier?
Oh yeah, yeah. This is just one of them that we had. Let's see. There. So yeah, this guy was, I think he was in his 20s. Vapes marijuana. So vapes THC oil, which is not all of the cases that have been reported. So there's some like 600 cases that have been reported. And in the New England Journal article that reviewed the Wisconsin, Illinois patients, the majority of them had inhaled something that contained THC substances in it, which of course oil-based, whereas most of the commercial vapes that are out there are the flavored ones are, at least the manufacturers claim, and they do have to go through the FDA to some extent or something, are not oil-based, and they use food additives, which of course I still would argue that food additives are meant to be eaten, not necessarily inhaled. But you can see this has a very, I'll show the chroma, I think just the resolution is a little bit better. Yeah, because they do thicker cuts. But it's this very nice subpleural sparing, and it seems to be common in a lot of these patients. I don't know why. I don't still have a good idea. There's been a couple of thoughts. You know, there was from New York State, they talked about vitamin E acetate, which in these vape pens, a lot of these kids and other adults alter them to increase the voltage and do stuff with them to they hyperheat these liquids to 300, 400 degrees sometimes. So you're inhaling these gases, and you can imagine vaporized grease when it starts to cool sort of coats the lungs. So there was the other paper from Utah where they talked about the lipoid, the lipid-laden macrophages. Well, not specific. That's something we've seen, we on the webinar. I know Howard's shown a couple of cases where that was one of the commonalities. We haven't really bronched any of ours here, but that's one thing that people have been reporting. So it's probably a bunch of different things, and I think it's being better recognized now. But we've seen cases that look more like HP with central lobular ground glass nodules. We've seen cases, Howard showed that one case where the patient required ECMO, was more of an ARDS clinical picture and a diffuse alveolar damage pattern. There's one that was a questionable eosinophilic reaction. There are a couple case reports of diffuse alveolar hemorrhage, so it may be that there's some vasculitis induced, but it's probably not one injury, and there's so much variability in how they vape, how much they vape, what they vape. Some of them tend to use a variety of different ones. There's all the different flavors. Mango seems to be the popular one, from what I can gather. But this OP pattern that I'm showing here seems to be the most common one that we're encountering. I had the other one I had this week had a radiograph that you could tell in the radiograph, you could see the subpleural sparing, and just you knew it was going to be a vaping case with that history. But you still have to exclude some other stuff. But these are often young and healthy people. Some of them seem to have prodromes of. I've seen one on an abdominal CT because they present with abdominal pain. Some of them will have weight loss. I've also, we had one patient here, I think it said buried in the chart that patient had multiple episodes of shortness of breath, would quit vaping for a while, feel better, and then start vaping again. So there may be some limited.
To celebrate.
Yeah. But it's very steroid responsive. And so there may be a component of eosinophilia, but I don't know. It's kind of interesting. But yeah, there'll be more coming in, but I think maybe hopefully it'll slow down, but we've had 6 fatalities now.
Yes, and the first Washington State case was reported yesterday. So we haven't seen this out here very much. And this person was I think it was a 15-year-old who was hospitalized for 5 days and is recovering at home. And he had, I think they said that he used a THC product.
Something about 80-something% of them.
Yeah. So, by the way, you guys put that letter to the editor into the New England Journal. When will that be coming out in print? Because I guess that was the online version. It was there as of Monday or something like that.
Friday, it posted Friday afternoon. Yeah.
So do you think it'll come out later this week, maybe today? In print?
Yeah. I don't know. I don't get the print issue. I can't get the PDF of it because our library, our library has it. I think it has to come out in press first.
Okay. Now, are you guys putting together a bigger series than that, or is that your cooperative publication?
We had a pictorial essay accepted by the Yellow Journal, AJR.
Good.
Yeah, so
Okay.
it's in process and now getting done. So, but they accepted that. So there'll be something out for the radiology committee with a lot more examples.
Now, I was away last week, by the way. Was there a conference on Thursday last week?
There was I was unavailable. I had a conflict, but Howard took care of it.
Okay. I haven't seen any cases.
Yeah, I think well, he and Travis are away this week, so we're kind of
Oh,
playing tag team.
very good.